Yes, good evening, Sanele. Thank you very much for joining us. Welcome on this platform.
Evening, I can hear you very well from Namibia.
Yes, I just wanted to mention this. I think I've prepared to say that on a personal note, Dr. Ndaba is one of our mentors, both me and Billy, and we really learned a lot from you. And also on the professional note, very passionate obstetrician, not only regarding patient care and management, also especially with teaching. And I'm sure most registrars in the Pretoria circuit will allude to your efforts, especially with teaching us. And we are very honored to have you tonight. And I'm sure there's no any other person better to tackle this topic of obstetric hemorrhage, which is still one of the leading challenges among our women in this part of the world, causing maternal morbidity and mortality. So we are excited to have you tonight, and I'm looking forward to the talk. I think we are good to start.
Thanks, David, for the introduction. I will share my slides now and I will start. Let me show my face first so that people know who's speaking. They've said I'm Dr. Sanele Ndaba, based at Kalafong Hospital. I'm in the obstetric unit there. So they gave me a huge topic today to talk about obstetric hemorrhage. It's a huge topic, but I tried to make it simple and practical for everyone in the platform so that we can benefit from the talk. Can you see my slides?
Yes, sir. Okay, you may put them on full screen. Perfect. Thanks.
Perfect. Okay. Thank you. So I'm going to start with the definition. By definition, obstetric hemorrhage is bleeding related to pregnancy. It can occur during the pregnancy, during childbirth, or in the postpartum period. Majority of the time, it typically presents with vaginal bleeding, but it can occur that you have intra-abdominal bleeding. For example, patients with a ruptured uterus, they don't present with PV bleeding sometimes, they bleed into the abdomen. So it is the most common cause of death worldwide. It accounts for about 30% of deaths worldwide. And in South Africa, it accounted in between 2014 and 2016 for about 16.9%. It is the second direct cause of maternal deaths in South Africa. The sad thing about this obstetric hemorrhage is that more than 80% of the deaths from obstetric hemorrhage are avoidable. So we'll just look at the magnitude of the problem. So this is a report from the Saving Mothers, Saving Babies 2017. As you can see from the obstetric hemorrhage accounts for about 16% of all the maternal deaths in South Africa. It is number 2 behind hypertensive disorders of pregnancy as a direct cause of maternal death. And it is number 3 overall maternal death cause in South Africa. So from Saving Mothers, Saving Babies from 2014 to 2016, we had 624 maternal deaths, accounting for about 16.9%. There was a slight improvement in 2017 because the maternal mortality from obstetric hemorrhage is around 16%, but it's just a marginal improvement. So it's a huge problem. As you can see from the graphs, if you look at the arrow where I'm pointing at obstetric hemorrhage, from 2011 up until 2017, there hasn't been any much movement in actually decreasing the maternal mortality from obstetric hemorrhage. There is a slight decrease, but we are not yet there. We are not winning, especially with obstetric hemorrhage and hypertensive disorders of pregnancy. And all these causes of maternal deaths are actually easily prevented. So one thing that is disturbing in this slide is that obstetric hemorrhage occurring at the levels of care where there are specialists, there were 102. 60% of them, these patients died in places where there is specialist care. So we should be worried if people are going to be sent to us as specialists and we are failing them and they are still dying in our care. It's a very worrying statistic. So from Saving Mothers, Saving Babies again, it shows that majority of the patients that bleed after delivery is either they bleed during cesarean section or after cesarean section, and they can bleed from PPH from other causes. but postpartum hemorrhage accounts for about 418 of the deaths from obstetric hemorrhage. Antepartum hemorrhage accounts for 108. And I want you to look at the bottom of the slide. At the bottom of the slide, majority of these patients had cesarean sections. And when they further analyze the reports of the maternal deaths, most of these patients, the indications for cesarean sections were not very quite clear. So we are doing unnecessary scissors and we are causing a lot of mortality and morbidity to our women. And the other thing that I wanted to focus on is that most of these patients died from hypovolemic shock. We managed to do the hysterectomy if she needed a hysterectomy, but they died from hypovolemic shock. 37% of them had a coagulopathy, they were in DIC. So I think that we tended to concentrate more on the obstetric management of hemorrhage and we forgot about resuscitation. So today's talk is going to be more on the resuscitation side than the management of the obstetric emergency or the obstetric management of hemorrhage. So as I've said before, to prevent all these deaths, it's very simple. First and foremost, we start in the antenatal period to identify women with anemia, investigate them, you correct the anemia. So by the time they go and deliver, they should have an HB of at least more than 11.1. They should not be anemic. If there's iron deficiency, we should correct that. The second thing is to identify women at risk. If we are seeing someone at the clinic with twins, polyhydramnios, previous postpartum hemorrhage, retained placenta, those patients would be optimized and transferred to a higher level of care because we know that what determines the outcome of the current pregnancy is what happened in the previous pregnancy. So we should identify women at risk and we should be referring them to higher levels of care. The other important thing is to have supplies. We must have oxytocin in our peripheral hospitals, in our clinics, in our hospitals. Internal tamponades should be available for nurses, midwives, everyone who works in the obstetric unit. Transfusion services should all be available throughout any institution that delivers babies. Prolonged labor, we know it's associated with atonic uterus and postpartum hemorrhage. So use of a pathogram, simple things like using the pathogram to manage labor can decrease the chances of having postpartum hemorrhage from prolonged labor. If we do more assisted deliveries for the second stage of labor, we decrease the morbidity. We know second stage scissors are associated with lots of morbidity and mortality and hemorrhage. So if we avoid those by doing assisted deliveries, we are going to avoid deaths from hemorrhage. And we saw most of these patients die from scissor or after cesarean section. Active management of the third stage of labor. We should not be leaving placentas for hours and hours and hours until patients bleed. So we should be actively managing it. If we can't remove the placenta by control contraction, you must try manual removal of the placenta. And it's in the scope of midwives, medical officers, registrars, anyone who works in a maternity unit should be able to do a manual removal of the placenta. And then lastly, we must recognize, we must have dedicated wards and areas where we are going to monitor these patients post-delivery or post-cesarean sections. We look out for vaginal bleeding in the vitals. And we can do this simply by using the early warning charts. So the biggest thing with hemorrhage is that it is often not recognized or we underestimate the blood loss. And the blood loss is underestimated because in pregnancy, signs of hypovolemia do not show until large amounts of blood is lost. And the reason for this is because of these physiological changes or adaptations for these women that are going to deliver. So the body already adapts knowing that there was a delivery, there's going to be bleeding. So you get your increased cardiac output, your stroke volume, your plasma volume is increased. This pregnancy, we know it's a hypercoagulable state. So all these are in preparation for delivery. So that's why these women tend not to show early when they are bleeding. Unlike a non-pregnant patient, after a liter of bleeding, if you are a non-pregnant patient, you will show signs early. But these women, because of the physiological adaptations, they tend to present late with signs of hypovolemia. So this slide shows the stages that were adopted from the College of Surgeons, but they are adopted for obstetrics. So stage one, we know that postpartum hemorrhage by definition in obstetrics, if you are post-normal vaginal delivery, it's more than 500 mils. If you are done a Caesar, it's more than 1,000 mils. So when you lose 1,000 mils, these patients show no changes. Their vital signs are normal. If you do your lab investigations, they are normal. The clinical picture of the patient remains normal. Then stage two, if you've lost between 1,000 and 1,500 mils, they still remain normal. clinically they are well, they will not show signs because they are resilient. Remember the adaptive changes. But when you get to stage 3, when you lose more than 1,500, that's when you are going to start seeing signs. Remember, if you decrease your blood pressure, that is a late sign. So your shock index will go up. Your urinary output will decrease. Then you can go into DIC. Your lactate goes up. Then sometimes these patients get to mental status, they get confused and lethargic. By the time you get to stage 4, they have severe hemorrhage. They have cardiovascular collapse. So the way I always teach people at Galafong, I always say postpartum hemorrhage is like a bus. You see it coming, you anticipate that is going to happen. So you assess the risk. When it comes, you must be ready. Your drugs for managing postpartum hemorrhage, your tamponade, your theater must be ready when the bus arrives. Once the bus passes you at stage 4, it is very difficult to get these women back. They die. So you must not allow them to get to stage 4. So these are just the signs of hemorrhage. Sometimes they present with pallor, they are confused. The first thing that is going to alarm you that there are problems is the heart rate. The first thing that goes up. By the time you see a decrease in your blood pressure, it's a late sign. That patient has lost more than 2 liters of blood. The other thing, antenatally, for example, the abruptio placenta, they usually present with abnormal fetal heart rates with bleeding. So you must be careful for a bleeding patient with an abnormal CTG. They get you decreased urine output, and sometimes they get an obvious bleeding like an open abruptio, or they get hidden bleeding for a concealed abruptio, but the signs are there, so you should not ignore them. So how do we recognize these patients early? Majority of our patients that come with abruptios and bleeding come with severe hypertension. So when the blood pressures drop, they look normal. So one thing that is going to give it away that this patient is sick is the pulse. So we use the shock index. Your pulse should not be more than your systolic blood pressure. For example, in this patient, the blood pressures look normal. It's 120/80, but the pulse is 143. So this pulse is more than the systolic blood pressure. It gives you an indication that the shock index of this patient is more than 1. So we can also use the shock index when we are resuscitating the patient. So if the patient is improving with our resuscitation, we should reverse the shock index. It should be less than 1. But if we are not doing well, we are not winning with our resuscitation, the shock index is going to be more than 1 and it's going to worsen. So we can use it as an early detection for problems, and we can use it as a measure of resuscitation to see if our resuscitation is working or not. So always remember, we no longer say now ABC, we call it CAP, circulation, circulation, circulation. If you don't have circulation, even if you can give oxygen, it is not going to be transmitted to the peripheral tissue. So first things first, you must secure good IV access. You must send blood to the blood bank and to the lab to order blood and blood products. You can give fluids, but if blood is available, remember these patients bleed blood. So if you are going to resuscitate them, you must resuscitate them with blood. They have lost blood, so you must give them blood. You must monitor the urine output, put in the catheter. Always be careful and be wary of a coagulopathy or coagulation disorder. So the way you manage these patients, it's a multidisciplinary team. You need a team, you need good communication, you need a team. Your resuscitation should be goal-directed. Management should be goal-directed. Immediate recognition and treatment and resuscitation should be initiated wherever the patient is bleeding. Medical, surgical, and other interventions to stop the bleeding follow after, but the initial one, first and foremost, the most important, is resuscitation. Start resuscitation early. If you are going to take these patients to theater and they are bleeding, if you've got that option, the resources allow you to, you can also activate the cell salvage facilities if they are available in your institution. Remember, if they have bled too much, you can actually give them factor 7 for managing the PPH. So communication and teamwork, remember there should be a leader. And the leader ideally should not be involved in the resuscitation. The leader should be the person who's giving instructions to other people who are involved in the resuscitation. Call for help early. You can't manage these patients alone. So when you call for help, you call a consultant, you call a colleague, you call blood bank, you call the anesthetist. Everyone must be on board to come and help with these patients because they can deteriorate very fast. Alert blood bank. So if you've got protocols within your hospitals to say that there's a bleeding patient, you activate the transfusion protocols in your hospital. Follow departmental guidelines and always have records. Someone must keep records of all the resuscitative measures that have been undertaken during that resusc. So when we say goal-directed management, what is that? Early recognition, institution of hemorrhage protocols. So each hospital has its own protocols. So early recognition that this patient is bleeding, you start with initiating hemorrhage protocols. IV access is very important. Administer IV fluids, administer blood as soon as blood is available. So if you start early resuscitation, you are going to avoid massive transfusion. If you avoid massive transfusion, you are going to avoid the complications associated with massive transfusion, which include acid-base disturbances, TRALI, hypercalcemia, hypothermia, thrombocytopenia, DIC. Efficient teamwork and decision-making, very important. The leader must make decisions early. You do not wait for a bleeding patient. If you've initiated the first step, you've given oxytocin, it's not working. Go to the next step, symptometrin, it's not working. Go to the next step, put in a balloon. If that is not working, you must timelessly go to the next step because if it passes you the bus, you are not going to catch it. So you must be on top of your resuscitation. Decision-making must be very, very, very efficient. Remember, cell saving was an issue with doing cell saver in pregnant women. The concern was that you might transfuse the woman with amniotic fluid, blood containing amniotic fluid, and there were concerns of hemolytic disease of the newborn. So these were put at rest because the amniotic fluid and the blood, before it is put back to the patient, it is filtered, it is washed. So there are no real concerns of transfusing a patient with amniotic fluid and getting a reaction from the amniotic fluid. And remember, if you are going to do cell saving, you must give these patients anti-T because there's increased fetal-maternal hemorrhage, especially the Rh negative ones. And you must do the Clay-Howard test 1 hour after giving the anti-T so that you can calculate the additional anti-T that is required in cases of massive fetal-maternal hemorrhage. Massive blood transfusion protocols were developed earlier before so that we can actually get requests and transport of blood quicker. These protocols have shown to be useful in facilitating rapid sufficient transfusion of blood and blood products. They improve communication because once you say to your blood bank, there's a bleeding patient, activate a transfusion protocol. They know exactly what to do. They know what blood products to send. So you must activate this transfusion protocol once the blood loss is more than 2,000 and you do your fibrinogen is less than 1, then you must start activating the massive transfusion protocol. The issue with the transfusion protocols is that sometimes we trigger it when there is no need. So we overestimate blood loss, we trigger it, and we end up having wastage of blood. We're giving blood products that are not going to be given to the patient. Then that costs the state a lot of money. So this is just an example from the American College of Medicine, American College of Obstetrics and Gynecologists, where they activate their own transfusion protocol. It goes according to round 1, round 2, round 3. So as long as there's continuous bleeding, you don't deactivate the transfusion protocol until you stop the bleeding and the patient is responding to the resuscitation. So I wanted to talk a bit about fluids. When a patient bleeds, they bleed blood and blood products. So if you are going to give them fluids, the aim is just to maintain a mean arterial pressure of 75. That is required for perfusion of the peripheral tissues. So you can't give non-stop fluids to patients that are bleeding out with blood, because if you continue giving excessive fluids, you are going to cause more damage than good. There's what is called dilutional coagulopathy. So they go into DIC. They become metabolic, they have metabolic acidosis. They have tissue edema, tissue hypoxia. Then they form a vicious cycle of coagulopathy, acidosis, and hypothermia. So if you are going to resuscitate patients, resuscitate them with the aim of maintaining a blood pressure and getting blood and blood products as soon as possible. There's a move away now when we are resuscitating bleeding patients from giving them fluids. We need to give them blood and blood products to prevent all the complications associated with excessive fluid resuscitation. Remember oxygen therapy to all these patients. You must cross-match. If you've got emergency blood, give them emergency blood. I think in all obstetric units, we should have fresh dried plasma to start immediately, because we don't want to give them fluid. We want to give them blood products because they go into DIC if we give them fluids only. If you are going to give them fluids or blood, use blood warmers. Keep the patient warm. You can start considering, when you've activated the massive transfusion protocol, putting up lines, or A-line and CVT for more invasive monitoring. Remember this vicious cycle is the worst thing ever. So whenever you're resuscitating someone, you must think of these three things: hypothermia, coagulopathy, and acidosis. So if you are going to resuscitate a patient proper, we must break this cycle. How do we break this cycle? To manage hypothermia, as I've said, if you are going to give blood, use blood warmers. Give the patient warm blood so that you don't decrease the temperature. Because if they are hypothermic, there's going to be impairment of the coagulation cascade. This is going to lead into DIC. If there's DIC, they are going to bleed further. What's going to happen if they bleed? They are not going to perfuse their tissues. Your lactate is going to go up. You are going to be acidotic. And what happens when you're acidotic? You have got myocardial dysfunction. So your cardiac output is going to decrease. So it's just a vicious cycle that worsens and worsens. So the aim of resuscitation is to break this cycle. If you don't break this cycle, then you are going to lose the patient. So what is the response you are looking for clinically? Remember, your aim is to have a mean arterial pressure of 65. That mean arterial pressure of 65 will allow tissue perfusion in the periphery. You want to decrease the pulse rate to at least less than 100. You want a urine output of more than 0.2 mils per kg per hour, and you can use the shock index to check clinically if your patient is improving or not. When it comes to the lab, remember, we don't have to transfuse these patients to HBs of 12. The target HB, according to the British Committee of Standards in Hematology, they say you must at least transfuse the patient to an HB of 8, aim for a platelet count of more than 75. Your PT and the APTT must be less than 1.5. You must aim for a fibrinogen of more than 1. And you must try and decrease your lactate to a less than 1. Remember, lactate is an indicator of peripheral perfusion. So if you don't perfuse peripherally, you are going to have a high lactate. If your resuscitation is working, you are perfusing the peripheral tissue, your lactate is going to go down. So these are some of the investigations. Remember, if you bleed heavily, you might have an acute kidney injury, so you must look at the renal function. Look at your full blood count, where you are going to look at the platelet count. Do your coagulation studies. Check if the patient is in DIC. Do your arterial blood pressures to check the metabolic status and the lactate levels of the patient. So you must have baseline of all these bloods so that when you are resuscitating the patient, you go back and look and see if you are improving when it comes to your metabolic status, your coagulation status, your calcium. Remember, calcium is required in the cascade, in the clotting cascade. So you must look at the calcium and replace calcium whenever there is hypocalcemia. Even with the transfusion itself, it causes citric acid toxicity, which further decreases the calcium. So you must replace calcium when you're resuscitating these patients. The use of thromboelastogram, I'm going to talk about it in the next slide. I think it should be the new standard of care in all maternity units. This device is a very nice device. It tells you a lot about what is happening with the coagulation status of the patient. The nice thing about it, it tells you what the problem is and it gives you the treatment option or the treatment that is required for that patient. So it will tell you about the clot formation, stabilization of the clot, and fibrinolysis. So if you look there, it will tell you what actually is the problem, interpreting the graph here, and it tells you what treatment you need to give the patient. So the nice thing about it, it's a point of care test. You obtain results within minutes. It provides information about the clot initiation, propagation, and fibrinolysis. It is diagnostic, and it also guides with therapy. You can use it to reassess and look for further need for any other blood products. So remember, complications of transfusion. If you transfuse too much to an HB of 12, you can actually cause circulatory overload and pulmonary edema. Transfusion reactions, you should be careful of those. As I've mentioned before, citrate toxicity causes hypocalcemia, so you must monitor your calcium. Hypothermia, if you're going to transfuse someone with cold blood and cold blood products. Correct the UNEs. Don't forget the late complications of massive transfusion. So these are some of the drugs we use in obstetrics. I think everyone is familiar with them. Initially, we always give prophylactic oxytocin, which is 10 units. At Caesar, they give 2.5 slowly. And if you are worried, the patient has got risk factors, you can give them 20 units in a liter as an infusion. Remember, if this does not work, you go to the next step. You give either ecometrin or symptometry. Early administration of tranexamic acid has been shown to improve death and postpartum hemorrhage. Misoprostol also can be used as a uterotonic. Remember the woman's trial that has shown that use of cyclocapron on its own decreases mortality and morbidity, and it actually decreases hemorrhage itself. So I'm going to talk, this is why I said in this topic, I want to concentrate more on the resuscitation, because that's where we lose most of our patients. Taking the patient to theater and doing a hysterectomy is fine, but if you don't initiate the resuscitative steps initially and you rush the patient to theater, if you rush someone unstable to theater, there's increased risk that that patient is going to die in theater. So that's why I wanted to concentrate more on the resuscitation of these patients before we actually talk about the actual hemorrhage itself. So I'm going to start talking now about antepartum hemorrhage. We know the three main causes of antepartum hemorrhage is your placenta abruptio previa and antepartum hemorrhage of unknown origin. So placental causes account for about 70% of all the causes of antepartum hemorrhage. There's 25% where it's unknown, and the extra placental, which is your local causes, account for 5%. Out of that 70%, 35% is placenta previa, 35% is an abruptio placenta. Remember CA cervix, remember polyps, remember varicose veins of the vagina can bleed. So remember, abruptio is a clinical diagnosis. You've got a tender and large uterus. Usually the uterus is bigger than the gestation, expected gestation. The degree of shock not always proportional to the revealed blood loss. Remember, a concealed abruptio. Sometimes they present with fetal distress and bleeding, and sometimes with fetal demise. Complications could get acute kidney injury, clotting problems, and you must always anticipate postpartum hemorrhage in patients with placenta abruptio. So how do you manage them? Circulation. Resuscitate the patient. Make the diagnosis from your history and examination. Control the bleeding. And the management of an abruptio placenta is delivery. So if you see a patient with a live baby, the mom is unstable, resuscitate the mother until the mother is stable. Never take an unstable mother because you want to save the baby. You are going to lose both. You resuscitate the mother, you reassess. If the fetus is still alive, then you can take this patient for an emergency cesarean section. Take home message, never take an unstable patient to theater. You are going to cause more harm than good. If the baby is dead, resuscitate. Induce labor by rupturing membranes, order 4 units of blood, 4 FFPs. And the main thing here is that you must give these 4 units of blood and FFPs before this mom delivers, because you want to optimize the mom. You know the mom is going to have postpartum hemorrhage. So you don't want the mom to have postpartum hemorrhage in the background of an unresuscitated mother. So you give the blood as fast as you can. If the patient does not go into established labor after 8 hours, you can consider a cesarean section. So that 8 hours of waiting, it is the time that you resuscitate the mom. Make sure the mom is fine. If you are going to take her to theater, take a mom that is okay to theater. Don't take an unstable patient to theater. If you are in a peripheral hospital, rupture membranes, start the resuscitation and send the patient. I'm going to talk about placenta previa a bit. So remember, all patients that present with bleeding do not do vaginal examination. You need to do a transvaginal ultrasound to exclude the placenta previa. You do a speculum exam to exclude local causes. So all placenta previa should be managed at a level of care where there are specialists. There is blood bank. There are blood and blood products. If you are in the periphery, all those patients should be referred to a higher level of care. It is essential, even in that higher level of care, the person who does the surgery must be the most senior and the most experienced person. It is advisable, if you are going to go to theater for a placenta previa, take along a tamponade. This can be your Bactrim balloon, it can be your Elavi, because they tend to bleed from the placental bed. So if you put the Bactrim there, you actually compress the placental bed and the bleeding is minimized. You can do that prophylactically, or you can put it in when you see that the patient is bleeding. Take home message with placenta previa. If you've got a placenta previa In a patient with a previous seizure or a previous uterine surgery, refer that patient to a tertiary hospital where they are fetal-maternal specialists who can actually scan and see if she's got a morbidly adherent placenta. Do not take a patient with an anterior placenta previa to theater in a peripheral hospital. Those patients need to be assessed and they need to have a good planning and multidisciplinary team to deliver them in a tertiary hospital. So antepartum hemorrhage of unknown origin is when you have excluded all the others, previa, abruptio, and the local causes. Usually 50% of these patients have got atypical abruptio. If they are going to abrupt, they are going to show you within the next 48 hours. So that's why you admit them, 48-hour observation, you do 6-hourly CTGs. So early signs that the patient is abrupting is going to be spontaneous decelerations on your CTG, or they will start bleeding. So you keep them for 48 hours. If the bleeding stops, the CTGs are fine, then the patient can be discharged home and delivered at 38 weeks. But if it's spontaneous decelerations and the bleeding persists, you deliver those patients by cesarean section. Let's talk about postpartum hemorrhage, our biggest problem. So postpartum hemorrhage, also risk factors. You must see the bars coming. So you must look at things that can cause uterine atony. If this patient had a previous PPH, prolonged labor, if you've induced this patient, prolonged third stage of labor, a retained placenta, big baby, anything that is going to cause over distension of the uterus, already you are anticipating that patient is going to bleed. So that patient should have a catheter, should have an IV line, should have blood on standby, because you are anticipating problems. Patients that have got preeclampsia, amniotic fluid embolus, sepsis, patients who have received massive transfusion, or patients who are on anticoagulation, those are also risk factors for DIC and coagulopathies. Remember, if you are going to do forceps, especially with instrumental deliveries and cesarean sections, they can tear. So you must also be ready to suture the patient if you are doing an instrumental delivery. Placental problems, your placenta accreta spectrum, always diagnose that early, because these patients are going to need a higher level of care, the specialist level of care. So the 4 T's of postpartum hemorrhage. Majority of the patients that are going to bleed postpartum are going to bleed from uterine atony. The next one is going to be trauma, laceration of the vagina. Then it can be retained products, or they can be a coagulopathy. So with the uterine atony, remember, simple basic things. Deliver the placenta, be very active in the third stage of labor, rub the uterus, do bimanual compression if the uterus does not contract. You give oxytocin infusion. You must always empty the bladder. If that does not work, you go to the next level. Symptomatic if the patient is not a cardiac or is not a preeclamptic. Give cyclocapron early. You can give misoprostol. In cases where the bleeding is continuous and you can't stop it, you are waiting for help to arrive. You can do aorta compression. If the bleeding is ongoing, you can use tamponade, uterine tamponade, you can use your PACT, you can use your LRV. You prepare the patient for examination and anesthesia and laparotomy. Remember what I said, timelessly make decisions to go to the next step. Do not delay. If the bus passes you, you are not going to catch up with that bus. So this is just pictures showing that at Caesar, if there's an atonic uterus, you can do the Billinch suture. You can put in a battery balloon or an LRV. If you are in labor ward and the patient is not at Caesar, do bimanual compression until help arrives. So WHO came up with this emotive acronym. This is meant for people working at the lower levels of care, your clinics, your MOUs, obstetric units. So they say you must early recognize, be active in the third stage of labor, recognize that the patient is bleeding. Simple things, you rub the uterus, you give oxytocin. If oxytocin does not work, you give cyclocapron. Start resuscitation. Give fluids if you are in the periphery because there's no blood there. Start resuscitating with fluid. Examine the patient there. If the patient can be sutured, there's a tear or a vaginal laceration that can be sutured, suture it. Treat the refractory postpartum hemorrhage. So it starts where the patient delivers, even if it's at the clinic, even if it's at a peripheral hospital. Start resuscitation. So postpartum hemorrhage, four things that you must always remember. Everyone who works in a maternity unit who's part of the team, it can either be a midwife, obstetrician, anesthesiologist, hematologist, or the blood bank. They must know about postpartum hemorrhage. There must be protocols in place to say that this patient is bleeding, we are activating the transfusion protocol. So everyone must be at par. Everyone must be at the same level. You must not have a situation where there's a return placenta, a midwife waits for a doctor. It is in the scope of a midwife to do a manual removal of the placenta. Earlier on, recognize patients who are anemic antenatally. Remember, anemia is the twin of postpartum hemorrhage. If you are anemic antenatally, you're most probably going to have postpartum hemorrhage. So treat anemia, give patients iron supplements, active management of the third stage of labor, you give oxytocin. If that does not work, you go to the next step. Early recognition and respond to the treatment. Remember, when you see these patients, you must look at the tone. Are there retained products? Is there trauma? Is the patient coagulopathic? So these are things that you must assess. They are basic things that anyone who works in a maternity unit should know and should be able to manage. So when it comes to a retained placenta, ideally, it should be removed within theater, anesthesia. But if the patient is bleeding and it's impossible to wait for theater, or you are at a clinic, or you are at a lower level of care where there is no theater, you do the manual removal at the labor ward immediately, because the longer you keep that placenta there, the patient is going to bleed. By the time they get to a higher level of care, these patients are hypovolemic, they are acidotic, they are in DIC. So it is level of a midwife to do a manual removal of the placenta. But having said that, remember to give these patients analgesia. So this is basically a picture showing how you do a manual removal of the placenta. So first and foremost, you must understand where the placenta is lying. Is it anterior? Is it posterior? So you hold the cord, you feel where the placenta is, and then you gently, with your other hand, supporting the fundus, go and separate them. You don't pull it, you separate it until you get to the fundus, and then you deliver the placenta. Remember genital trauma, examine, visualize the perineum, examine the vagina, examine the cervix by doing a cervical walk, explore the uterus manually, always repair with good light, ensure that the apex of the tear is secure. Because if they are going to bleed from a tear, they bleed from apexes that are not secure. Sometimes there are extensive vaginal laceration. For these patients, especially if you are in the periphery, you can consider giving them just a cyclocapron, 1 gram slow infusion. You can tamponade the vagina with a Bactrim or an Elavi, or you can pack the vagina and send them to a higher level of care. So if you suspect a uterine rupture, early recourse to theater with a senior assistance, you do an EUA, you do a laparotomy. It's either you are going to get there and repair the uterus, do a subtotal hysterectomy or a total abdominal hysterectomy. If you lack skill to do a hysterectomy, you can always tie the uterus with a catheter. I'm going to show you a picture in the next slide. But remember, if you are working in a maternity unit, medical officer, registrar, consultant, you must be able to do a subtotal hysterectomy. It's a life-saving operation. Anyone who can do a cesarean section should be able to do a subtotal hysterectomy, at least minimum. So this is what I'm talking about, the technique of tying the uterus. You go to the lowest you can go to the uterus and tie as hard as you can, clamp it and refer that patient if you're in the periphery, or you can tie and wait for senior help if you are in theater in a tertiary center. Meanwhile, you are tying, don't forget continuous resuscitation and reassessment. So how do you transfer unstable patients? It is important to initiate. I said in the beginning, in this topic, I'm going to talk and dwell more on resuscitation, because most of our patients that die do not die because the hysterectomy was not done. They die because they were not properly resuscitated. So if you are in the periphery, start resuscitation there. If you've got blood or blood products, start giving the blood and blood products there. You can use tamponade, you can put in a battery, you can tie the uterus with a Foley's catheter, or you can use the non-pneumatic anti-shock garment when you're transferring the patient. But most important thing, resuscitate continuously, reassess, resuscitate, reassess. See if your resuscitation is working or not. So if you are in the periphery, you don't have the luxury of battery balloons, you can use a condom catheter or you can use a glove. It works as a tamponade. Also, if you are in theater in the peripheral hospital, don't forget to do a billing for those patients with an atonic uterus, or you can do a stepwise devascularization of the uterus if you can. Remember, if you can't, you tie the uterus as hard, as low as you can and you clamp and you refer the patient to another level of care. This is a non-pneumatic anti-shock garment. The nice thing about this garment is that you can use it in a patient who is still pregnant. So if you've got an abruption in shock, you can continuously resuscitate, put the anti-shock garment, and transfer the patient to a higher level of care. So in conclusion, most important thing, antenatally identify patients with anemia, treat anemia. Identify patients at risk and transfer them to a higher level of care. Early recognition of hemorrhage, early initiation of resuscitation. How do we manage these patients? Follow protocols. Remember circulation, circulation, circulation. Remember these patients bleed blood, so you must replace blood with blood. Avoid excessive fluid resuscitation of these patients. Diagnose the cause and manage the cause of the PPH. And one important thing, skills training for professionals working in maternity. So continuous education, continuous drills in your hospitals and your clinics, it will help a lot in fighting this pandemic of obstetric hemorrhage. I thank you.
Wow. Thank you very much, Dr. Sanele. That was a very informative, beautiful, summarized presentation and straight to the topic. Very, very, very good presentation and very practical. So I think before we open the floor up and just look into some of the questions that we have received here in the Q&A, I just wanted to highlight a few issues that I think maybe you can just clear it up. One is the issue of abruptio placenta, and I would want to have your opinion on this. Most often you have a patient that abrupted in the periphery and sent to the next level of care, and say the patient arrives there 3 to 4 hours later. So we know that there is this time limit of about some say 6 to 8 hours, and then you must consider to deliver by cesarean section if the patient is not delivered by then. So the issue of the time, is it the time when the patient arrives at the facility or the time of the diagnosis of an abruptio? Can you just help us assist in to clear that up and see how, so that you can perhaps also help to manage the patients on time? Because my view is that the patient with an abruptio, until the baby is out, this bleeding is an ongoing progressive bleeding, and most often the morbidity, it appears that they end up with a worsening morbidity. Can you just comment on this?
The thing is, David, with patients, I understand exactly your frustration, because the patient, the problem is what I said before. Initiate treatment at the periphery. Resuscitation must start at the periphery. Rupture membranes at the periphery. So the time you are counting is when the peripheral doctor or nurse ruptures membrane until the patient comes to you. So when the patient comes to you, you reassess the patient. Is this patient stable? Can I give this patient 2-3 more hours and see what is happening? Remember, the time you are giving this patient 3 hours or 2 hours, it's the time you are continuously resuscitating and reassessing, because you do not want to take this patient to theater when the patient is unstable. You want to also to stabilize, make sure the patient is fine to go to theater. So sometimes you buy time and resuscitate the patient. There's nothing wrong in resuscitating the patient and passing that 8 hours. If you see that this patient needs further resuscitation and she's not stable enough to go to theater, remember, once you open that uterus, that bleeding is going to start again. So you do not want to start on a back foot. Resuscitate, resuscitate, resuscitate. But the hours you count is from the time the membranes were ruptured in the periphery, not when the patient arrives in your hospital.
Thank you very much. So I think that's very clear, and I think that's something that is always coming up. The next thing that and I wanted you to comment on is or perhaps also just to comment, is the targets for like the resuscitation goals, and especially the role of the arterial blood gas. We know that in most peripheral hospitals, you might not find an arterial blood gas, but colleagues that have access to blood gas, it is very, very important that we must make use of the arterial blood gas, because it really gives you the overview of the metabolic status of the bleeding patient and how the patient is responding to resuscitation. So the other point I just wanted to highlight is on the issue of resuscitation. One of you put up that massive transfusion protocol or chart. And one of the products that is always coming out there that we often not speak about is the fibrinogen. Can you perhaps just comment on that? The use of the cryoprecipitate. We know that fibrinogen is one of the clotting factors that often get depleted faster compared to the other clotting factors. Can you just comment on that? That when we are activating the blood products, cryoprecipitate, should it be part of that resuscitation when you say give us 4 RCCs, 4 FFPs, and should you also add cryos as part of the products?
Thanks for the question, David. The issue of cryo, you should be adding cryo. The problem for the longest time is that we were not having at our disposal results as quick as we would like. We used to send these things to the lab, and you know the lab takes a bit longer. So that's why I was saying, I think we should move towards using the TEG in all labor wards, because it's a simple test. It gives you answers quickly. It tells you if you need cryo. But if you are going to use the transfusion protocol, cryo is definitely part of the transfusion protocol. But remember also—
Thank you very much. I just wanted you to clear it up, because most often we do not add it.
No, that's why I'm saying it is part of the transfusion protocol. But remember, these protocols are different for different units. That's the other thing. So that's the other issue with transfusion protocols. They are not the same. The trigger is not the same. So you must have your own transfusion protocol in your institution. Remember there, when I showed the example of the American College, they use 6 units. They use mega units of platelets because they are coming from a resourced place. So they use all the blood products. They are readily available. With us, we might not be that lucky to have those. That's why in our setting, our transfusion protocol gives 4 units of blood, 4 RCCs, 1 mega unit of platelets, and cryo. So, but cryo should—
We used to speak about 8, right? They put 10 there. I think we used to use
10
8.
cryos. It's different for different institutions. That's the biggest problem with the transfusion protocols. It's not the same. It's not standardized. So we don't have a standardized everyone. You create a protocol according to where you are and the resources you have.
But for this part of the world, say if a patient is in Limpopo, how many cryos should the patient order?
At least 8 cryos.
8. Okay, good. Thanks. I think that's clear. Colleagues, at least 8 cryo is part of when you activate the transfusion blood products, when you order bloods and FFPs. All right, so we are going to then look into some of the few Q&As questions that came up through the Q&A. I think this is a very important question. One of the questions that is coming out, you really highlighted the importance of resuscitation. So one of the questions is on the choice of fluids. When we are using the crystalloids, should we use the normal saline or ringers as a fluid of choice in resuscitation? Can you just comment on this?
You must use ringers. Ringers is better. So use ringers. You can use colloids also, but remember, the only reason why you are giving fluids is to maintain arterial pressure or tissue perfusion. It is a temporal measure. If patients bleed blood, you must give them blood and blood. That's very important. But you cannot give more than 3 liters of blood and of fluid. You are going to cause dilutional coagulopathy. So give blood. If you are in your labor ward, you have got FTPs, start FTPs early. If you've got emergency blood, start emergency blood early. Because if you give a lot of fluids, you're going to run into trouble.
All right, thank you very much. This is more it's a challenging ethical question. You have a patient with a PPH bleeding to an HB of around 3, and the patient is a Jehovah's Witness. What is your advice on this? Or how should you advise someone to manage such a case?
You know, we've had cases like this. We had recently another one like this. You know, you must talk to the patient alone. Leave the relatives out of it. If the patient wants to be put in a room separate so that she is not seen to be receiving blood, it's okay. There's nothing wrong with that. But what is wrong is for you to give the blood when the patient says, I don't want blood. Majority of these people will accept blood. If you tell them this is the situation, if you don't do this, this is going to happen. We are not going to inform your relatives or whoever that you got blood. Let us put you in a separate room, transfuse you in secret, and then you go out and give fluids as if we were giving fluids. Some of them do agree to blood transfusion, but you must not give if the patient says no.
Thank you very much. So it's all about informed consent, and the patient makes the decision. Thank you. Yes. The one point, I'm happy that this came out of your presentation, the issue of you, the using the NASC, the non-pneumatic anti-shock garment. It is something that is available. I also happened to travel at one of the peripheral hospitals here in Namibia, and I was surprised that the colleagues there didn't even know what is a non-pneumatic anti-shock garment. And it is, you highlighted that it is very important, and you even put up a picture there that if you are referring a patient, please, and nowadays with this modern technology, we can just Google. If you put in non-anti-pneumatic shock garment, there will be videos on how to use this garment, and it can actually save lives. And it's, please, the colleagues that are in the peripheries, please familiarize yourself with this garment. And preferably, if you are referring a patient, the patient should be wrapped in this garment because it does really improve the morbidity and the mortality. It saves lives. So I'm just happy that you put it in part of your presentation. Someone was just asking about it. And then the next question that is coming up is the issue about the indications for a hysterectomy. Perhaps maybe you can just give one of the common indications for a hysterectomy in a bleeding patient.
So as I've mentioned, David, when you are managing PPH, you must decide. First step, if it's not working, you go to the next one. If the next one is not working, go to the next one. So you only go to theater, you do remember you put the patient in Lloyd Davis. Squeeze the uterus, see if you're gonna put a pillage, if the pillage is gonna work. If the pillage looks like it's gonna work, you do a pillage. If the patient stops bleeding, you stop. If the patient continues to bleed, because by the time sometimes you go to theater, they are coagulopathic. You correct the coagulopathy, you do a subtotal hysterectomy, or you can devascularize the uterus and see if the bleeding continues. So the decision to do a hysterectomy depends on the steps that you are following. If the step is not working, you go to the next one. If the next one is not working, you go to the next one. So there is no indication to say that this one must get a hysterectomy, this one must not. It depends on the steps that you follow when you are managing PPH.
Thank you very much. That's it.
If I can just come in on the just a small question on the issue of the team, the research team. You know, I'm thinking of district hospitals and some of the hospitals here where generally the teams might not even have enough people, you know, in the maternity space. How does it work, you know, at Kalafong? And also, who is this ideal team leader? And you have also mentioned that ideally they are not doing the research, but they are sort of leading and advising the team. I think, you know, is it really feasible in our setting? Because I haven't seen it being done that way. Thanks.
It's actually very feasible. You know, you don't need the most senior person who knows better should be leading the team. Remember, if you don't have hands, you can be part of the resuscitation because you don't have hands. Ideally, you should not be involved in the resuscitation if you are the team leader. But in cases where you are saying there's no hands, you will be part of the resuscitation, but you are still going to be the one in charge of the resuscitation and giving instruction.
Because I thought it was one of the best things you have mentioned, especially around communication. And I think there's a lot of midwives here and people who work in maternity. It's important that these protocols are in place and there's a clear, you know, activation of these teams and the processes are followed the way they've been described. I thought that was quite positive. Thanks.
Sure.
All right. Good. This is an interesting one. I actually had a discussion with my colleague. I'm also from that school of thought that if you have especially if you have an IUFD, abruptio placenta with an IUFD, the most principles is that you must activate 4 units of RCC, 4 units of FFP, and then now cryo is at least 8. So the argument was, and I see the question is that if a patient is having an IUFD and the patient is hemodynamically stable, and the argument was that if you have a patient, for example, with already underlying preeclampsia with placental insufficiency, you do not really need a significant amount of blood loss for you to have that baby demising. Should we activate these 4 units of RCC, 4 FFPs, and cryos for every patient with an abruptio with an IUFD? Can you please comment on this?
So this comes up a lot. So it depends where you are. The reason why they say you must activate that transfusion protocol is that we are taking into consideration the time the patient comes from the periphery to your own hospital. But if you are in a hospital like Kalafong, like Obstetric, where there's tertiary, everything is around, you don't have to bring all of them at the same time because you're going to waste blood. So you can bring, as you said, you do an arterial blood gas, you see where you are with the patient, you see the lactate, you see the vital signs, you see the shock index. You see that this patient is most probably resuscitated, she's fine. So I can order 2, and the other 2 can be on a PRP box. I can send it back to the blood bank if I don't need it. But if you are going to accept someone coming from another institution to another institution, that's a different story because you know abruptio is an ongoing bleeding process. So there is no way you can say you are going to not give this one because by the time they come to us, the ones who are coming from the periphery, they come very sick, already having bled out. So that's the issue. But if you are in an institution where there is facilities and things that you can do, for example, I mentioned the TEG. TEG will guide you. If someone like that do a TEG, if the TEG is normal, you don't have to order blood products. So it depends where you are. But when you are accepting someone from a periphery, those ones bleed and they take longer to arrive at the higher level of care. So that's why I'm saying that's how it was brought about to say that you must order the 4 units of blood for FFP. But it's not one size fits all.
Thank you very much. The one question that is also coming up is that if you have a patient with a placenta previa and a previous cesarean section, we highlighted and we are aware that they are at risk of placenta accreta spectrum. Should this patient be referred to the 3rd level or a tertiary center for at least a scan? I think the answer is yes. And maybe you can just add if. Yes,
and should be delivered there.
Yes, all right, good. That's clear. Thank you very much.
Yes. David, hi, David. After this question, you can try and take the hand after your next question. Yes. Thanks.
All right, good. The other one that is just coming up is the role of giving calcium gluconate as part of resuscitation in a bleeding patient. Can you just comment on that if you have that, and then we can take the hands.
So when you are giving blood and blood products, they have got a preservative. And that preservative is what? Is citrate. So citrate actually consumes the calcium when you are giving blood to the patient. So it binds with the calcium and you end up having hypocalcemia. And if you look at the clotting cascade from physiology, you need calcium as a cofactor for clotting. So if you don't replace that calcium, you're going to end up with 2 problems. It's either you're going to have citrate toxicity and the bleeding is going to be ongoing. So when you do your arterial blood gas, there's always calcium there. So if you've got low calcium, you need to replace it.
Thank you very much. It's very important. I think it's one of the important. Any hands up? Can we just have a look if there's, can't see, let me just see.
Yeah, there's Candolo, Platini,
yes,
Kabake. Yes.
Yes, I see.
Hi, Candolo.
I know I understood. I was about to ask, but Dr. Sanele already responded. Thank you.
Oh, okay. You may lower your hand. Thanks, David. You may continue.
Yes, I think we are almost coming to. So I just wanted to look at this. I once made improvise. I think maybe the one thing that you or I perhaps missed it is to emphasize the role of maybe you can just say something on improvised balloon tamponade, especially with a condom. We used to do this at Kalafong. Maybe you can just comment on this, and it's really something that can also save lives. How to do it? Because I've seen colleagues that do not really have the skills on how to do it and how it should be done.
Can I do this, David? Can I send a video of it being done? Because if I'm going to explain without someone visualizing what I'm talking about, they are not going to understand.
That's brilliant, and I think then
let's
Seho can share it on the platform. Yes,
I shall do that. Sure.
For sure, for sure. Dokotela Sanele, do we have TEG in the public sector outside of the big hospitals?
Teaching.
We actually don't. That's why most people now are advocating that all maternity units should have a TEG. It is actually a very cheap, and the biggest problem we have at Calafong with TEG is the consumables. The machine and everything is there, but we struggle with consumables. But I think all obstetric units, especially the ones that manage patients at a higher level, should have a TEG in labor ward. Registrars should know how to use it, should know how to interpret it, even medical officers. It will make your life easier. It's not available readily now, but I think there is a move towards having TEGs in all these levels, in higher levels of care where there are obstetric patients.
David, if I can just chip in again with just one question. Dr. Sanele, there's always, I just want to, in terms of deciding how to respond to hemorrhage, is it important to estimate the blood loss, or do you need to evaluate for shock and respond, you know? Because I see sometimes people get stuck on the technicalities of estimating the actual blood loss versus assessing a patient as to whether how bad is your patient in shock, and therefore how best do you respond. The same question applies to in pursuit of a diagnosis versus responding to the clinical picture or the immediate needs of your patient. I mean, I've seen patients being pushed to sauna rooms, even where one would have thought maybe a resus is what needs to be done. I don't know, how do you balance these kinds of questions? Thanks.
So for the resus and sauna, I emphasize in this presentation, there is nothing more important than the resus. The first person in contact with the patient should initiate resuscitation immediately. The baby, leave the baby alone. You can always document, because people have got this fear of saying the baby died in the hospital. Leave the baby alone, resuscitate the mother. Mother comes first. That's the principles of obstetrics. When it comes to blood loss, remember what I said, these patients are very resilient because of the physiological adaptations of pregnancy. They will not show you signs until they have lost at least more than 1.5 to 2 liters of blood. It's very important to estimate that blood loss early. Once you estimate that this patient has bled, you start doing your arterial blood gas, you start doing your TEGs, you start looking for problems. Remember, in obstetrics, you must look for problems. If you don't look for them, you are not going to find them. So that's why early recognition is very important. Look for problems. Estimate the blood loss. If you feel as a clinician that the patient bled, look for problems so that you can sort them early. Because by the time you wait for the signs, that patient is going. That's the biggest problem with pregnant women. And once the bus leaves you, you are not going to catch it. That's the biggest problem with pregnant women. Once you get to the stage 4 of shock, you are not going to reverse it. So rather use the estimation. Be truthful to yourself and say that I did a Caesar, this patient bled. Look for problems and try and sort the problems out, but don't wait for signs. Once the signs are there, it means the patient has bled a lot.
Okay, I think that is clear.
Yeah.
Thanks, David.
Yes, maybe you can just, I think, I'm sure most of the colleagues that have not been in the tertiary hospitals, they are struggling to understand what is the TEG. Maybe you can just elaborate on the TEG and the ROTEM and all that, what it is, and just in summary, not really to go into a detail. But you highlighted that it helps us to guide us, and it gives us which type of blood products. Maybe you can just summarize on that.
So a TEG is a point of care. The most important thing about a TEG is a point of care test that gives you results within minutes. So what it does, it tells you about the formation of the clot, propagation of the clot, the stabilization of the clot, and fibrinolysis. So it's a graphic representation there that you interpret according to if there is a need for platelets. The graph is going to sort of show you that if it's shaped like so, or the angle is like this, there's a need to give platelets. So it just gives you a diagnosis to say that this patient needs blood products. And it also tells you which blood products to give the patient based on the graphic representation at that time you are doing the TEG. So that's how it works, basically. It tells you about the clot formation and fibrinolysis of the patient at that point in time.
Good. I hope that summarizes, and I think it's a very, very useful test. And for me, the reason I also think your comments that every maternity unit should, and it will probably also save the state a lot of money, because there's also a lot of wastage in the blood products, and it's also safer for the patients. It prevents patients from massive transfusion of blood products, and I really think that it's something that is very, very important. So I think I've tried to answer some of the questions by typing in the Q&A platform. So some of the colleagues that have typed questions, maybe they can just have a look there. I tried to respond to some of the questions. So, I would just want to summarize up, I think, what we have learned today, and especially the most important take-home message is that we have learned that obstetric hemorrhage is still a problem and the leading cause of maternal morbidity and mortality in this part of the world. And for us is how to, number one, we must be able to recognize and to act on time that obstetric hemorrhage is happening. And one of the skills that we also have is with diagnosis, especially with abruptio. We need to just please remember that an abruptio placenta is a clinical diagnosis. Most often you will find colleagues that will say that there is no retroplacental clot, it's just an IUFD, and they manage the patient as any other IUFD. So that is also one of the errors that I have seen, especially with some of our medical officers that I have worked with this. And we have also learned that the most common cause, up to nearly 2/3 of all the obstetric hemorrhages, are related to a cesarean section. We just need to take home message that any cesarean section is a potential obstetric hemorrhage, and it can end up with a maternal morbidity. And the most important thing that I think we should take home message is the first thing is that we must have a good indication for a cesarean section. The next thing is the skills. You know yourself better that if you feel you are not skilled enough, it is always advised that you go to the next level of care for 2 weeks or whatever few weeks, and then you just sharpen up your skills and improve on your skills. And also to the interns, if they are interns on this platform, they must make sure that they take an opportunity during their internship to make sure that they really get the basic skills on how to do a safe cesarean section. And one of the points that were in the chart is that you didn't mention anything on the what? You didn't mention anything on the say corners at bleeding at cesarean section. Especially securing the corners at cesarean section is one of the most important skills. You need to identify the tears at cesarean section, and you need to secure those tears and also the corners. And it's all part of these skills that we really need to really sharpen our skills to make sure that we are doing a safe cesarean section. And the last point that is related to this cesarean section as part of the skills is most often us as surgeons, we do not want to be seen as if we are having our patients bleeding at cesarean section, because it could be perceived as if you are not doing a good cesarean section. And most of the time, we often underestimate the blood loss. And I think a surgeon is the one who should better give what is the estimated blood loss. And most often the mistake we do, we ask the anesthetist, what is the blood loss? But we are at the liberty of the uterus and see how much the bleeding is happening. We should be able to identify and know that the patient is bleeding. And the last point that I wanted to, that we learned today and we must take home message is the importance of resuscitation, how to do adequate and effective resuscitation, and how to monitor our patients that whether they are responding to the resuscitation that we are giving, more especially the importance of using blood products. I hope I've summarized up the most learning points, and Dr. Sanele, maybe you can just round up before we log off.
Thanks, David. I think the most important thing is that these deaths are preventable. More than 80% of them are preventable. It is just us healthcare workers, if we care enough. When I see someone in antenatal, I look at the booking bloods, I don't see an HP. It is my duty to make sure that I look for it. If it's not done, I do it. If there's anemia, you correct it. Small things that are very important. The other thing that is important, let us not leave midwives aside. If we are doing a manual removal of the placenta, the midwife must be part of it. It's in their scope to do these things. Because majority of the cases with retained placentas come from other hospitals, all the way to referral hospitals. So the doctors in the periphery should be comfortable doing these small procedures that can save lives, like manual removal of the placenta, inserting of a battery catheter or a condom catheter. Those things should be skills that are done in the peripheries, so that by the time the patient comes to us, at least the patient is no longer bleeding than sending someone who's bleeding, not resuscitated. By the time they come to us, they are very sick. So I think the lower levels of care, we've been neglecting them for a long time. I think our energy should be directed towards the lower levels of care. Let us kill those people there. Let us go and train them. Let us make them efficient enough so that by the time they send us these referrals, they send us good referrals. But if we keep it to ourselves in the tertiary institution and forget about them, then we are not going to win this battle.
Thank you very much, Sanel.
The most important thing, we need healthcare professionals who actually care. If you are a clever doctor, I rather have a caring doctor than a clever doctor. We just need to care.
Thank you very much. That is always that I also try to encourage our interns that sometimes that attitude of caring is very, very important, more than that academic knowledge that you're mentioning. Thank you very much for that. Seho, I think you can round up, and then I think from my side,
I think Sadele and David have done it all. I don't have much to say, except also to emphasize that we need to be very respectful to pregnant women. A smile, being compassionate goes a long way in actually, supporting women during this particular complicated experiences. So yeah, colleagues, thank you very much for joining us this evening. We will look at the questions. If there is more questions, we might set up a Q&A session.
Yeah.
Otherwise,
sorry. I think there's just this question that is very important. It says your take on perimortem cesarean section and resuscitation. I think this is an important question. We know of the case that happened in Limpopo a few years back. I'm sure maybe you can just comment on this.
So perimortem now I'm still here. Perimortem scissors are part of resuscitation. So perimortem scissors are done for patients that are getting cardiorespiratory support, CPR. If you are doing CPR and within the first 4 minutes, your CPR is not effective, then you do a perimortem scissor for resuscitative purposes, not to save the baby. So when it comes to postpartum hemorrhage, there is no room where a patient is fully conscious but is bleeding. You're going to do a perimortem scissor. If you're going to take them to theater, take them to theater for a scissor, not for a perimortem. Perimortem scissor is part of resuscitation in a patient that is getting CPR, not for hemorrhage.